I'm silent. Hello, everybody, and welcome. So people are just trickling in, so we'll just give it a minute or so. But first of all, I would just want to say thank you for everyone attending tonight's webinar. My name is Stacey. I am Head of Sales over at Swallow Dental Supplies. So I'm just here as one of your hosts. I will go through at the end of contact details and more details about anything about the quick sleeper afterwards. And then we have our guest host here, which is Andrew. And I'm going to pass it over to Andrew to introduce himself. And then after a minute or two, once we've allowed people to just drip in, we will start the webinar. So Andrew, do you want to go through and introduce yourself?
Absolutely. Thank you, Stacey. Good evening, everyone. A Wednesday evening after work. I'm impressed with all of you for coming on board tonight, and I want to thank you for doing that. My name's Dr. Andrew Prynne. I am a general practitioner based in Bournemouth on the south coast of the UK, and I have been in general practice for, I actually sold the business a couple of years ago, but before that I was 35 years in the same place. In fact, I was in the same place that I used to go and have my teeth done when I was a nipper. So effectively I'd spent my entire career in one building. Now I'm charging around the world talking about this stunning system, which I will not leave you in suspenders for long, and get to talking about as soon as Stacey allows me. I always do what I'm told, you see. So that's good. But yeah, I absolutely adored my career in general practice, and what was wonderful about general practice is you can focus down on the things that you genuinely enjoy. So one of the benefits of age is that I was able to do courses in implantology, use the beginnings of the digital era. I'm actually deeply jealous of everyone out there now using full digital systems and workflows that go digitally from beginning to end. But I'm carrying on my passion by talking about another digital system, which I will talk about tonight. And that's me.
Thank you. Thank you. One thing I will just say as well, we do have the chat function. If anybody does have questions while Andrew is talking, I will be keeping an eye on the chat box. Please feel free to ask questions. I'm sure Andrew will agree. The more questions you ask, the more you'll get out of this webinar. We don't want it to be just a bunch of slides and it's all finished. We really want people to be interactive as possible. No question is silly, so please feel free to ask the questions and I will help and assist Andrew with them questions. That is it from me. Thank you. I think we should let's get started.
Thank you, Stacey, very much indeed. So I hope everyone can see the screen all right, because I've got what Stacey said, which is a whole load of slides. So what I'd like to do tonight is, first of all, just say that I am an independent bod charging all over the place. As a key opinion leader, I do not receive any financial benefit from any sales of these devices, and but I will stand before you and recommend the purchase of them fully, because of the benefit that I want to show you tonight that I received from these systems. So as I said, I am Dr. Andrew Prynne, practitioner on the south coast of the UK for many years. And a statement here which I made many years ago actually now, but it really does show what an effect this had on my career. And it wasn't just for me, it was primarily for the patients. It was a stunning thing for the patients, and you'll hear from two of them in a little bit. But it also made a huge difference to my team, to the dental practice, and to the business of the dental practice. And I'd like to try and show you that as well, what effect it can actually have. But one of the things that made such a difference to me was my stress levels. They just went. So what I'd like to do tonight is give you a short, sharp, you see what I did there, a short, sharp summary and introduction of this stunning system. So let's start with a statement. I think you'll all agree with this, that without anaesthesia, we as dental practitioners cannot achieve what we want to do for our patients. We cannot do the treatment that is necessary. And anaesthesia, it really does form a trusting relationship that we have with our patients. And it is one of the first parts of any dental procedure. And it allows us, when it is done right, it allows us to create an incredibly strong trust and loyalty from our patients. Dental equipment has, over the years, certainly from when I started practice 38 years ago now, it has evolved. So in olden days, dentistry had a bad reputation for this very reason. An X-ray set 95 years ago may have looked like this, throwing X-rays in all directions, but these days we've got sleek, collimated digital systems. A dental chair may well have looked a bit like this, a little bit of a cross-infection nightmare, but today we have got slick, computer-driven electric chairs, easy to wipe down, very, very sophisticated. Back in the end of the 19th century, we might have been using an archaic device such as this to give our anaesthesias. But today, we're able to do much the same thing. So perhaps here there is an opportunity for some evolution. Now, what's wrong, I hear you ask loudly over the internet. What's wrong with traditional techniques? Probably nothing. I used them for many, many years myself. They work mostly, but there are some dark sides to traditional techniques, and I want to just briefly show you those. What is wrong with traditional techniques? Time. Time is a big factor which is hidden from us. We do not see this time ticking away. What happens basically is that we give anaesthesias and we wait. Even for an infiltration, we have a civilized period of waiting for the anaesthesia to function and to work fully. Now, this is an example of a spreadsheet which allows us to actually modify this to each of our own situations, but very, very conservatively, 5 anaesthesias a day. Maybe we have 2 which are a bit difficult per month and need repeating. So you can see this is quite conservative, and that might, with 25 anaesthesias a week, give us a total delay and waiting of 125 minutes. Added to the complicated ones, that could be as much as 135 minutes each week. And this, when it comes down to it, is a very costly experience for us. Clinical time is one of our most costly assets. So I'll come back to this a little bit later. So time is a problem. Control of patient movement. I think when you're holding a traditional syringe 1.5 miles away from your patient, you have very little control and support for your patient, and you lose that caring touch. I could not keep a needle still now at the end of a long syringe. That needle would be moving even with the slightest amount of shakes. So the control, precise control, is minimal. Collateral numbness is no fun. It's no fun for children, but it happens in adults as well. The loss of function is significant when someone can't feel their lip and they're biting their lip or their tongue and they're finding it difficult to talk, and maybe their face has lost some of the motor function. So this is something which it would be lovely to lose. These 2 characters here, the one on the left, I found on the internet. He's trying to whistle. He finds that extremely funny because he can't after having had traditional anaesthetic techniques. The lady on the right was wanting to go back to work after her appointment and is sitting in her car realizing that she can't go back to work because her face physically has fallen on her left side. Appointment management. If we are doing bilateral mandibular techniques, we will tend to do that over 2 different visits. And as such, we then have to bring the patient back for a second visit. Multiple appointments, failed anaesthesias. They do happen, and I'll explain briefly in a moment why they happen, even to the best of us. And stress. stress is a critical factor. None of us want to hurt our patients, and if our patients feel some pain or the eyebrow moves and the patient twitches, then the patient has suddenly realized, whoa, I may be hurt in this appointment, and their stress levels shoot up. And of course, the doctor, the dentist, does not want to hurt their patients. And the moment they see that twitch and they realize the anesthesia has not worked, their stress levels will shoot up. I would put it to you, even higher. Now, what would be our hardest and trickiest and most inconsistent anesthesia? It's probably the one for the hot mandibular molar. So let's look at the innovation of that. The inferior alveolar block is traditionally used for your hot posterior molar, and it is also statistically the most common dental anesthesia to fail. And this has been shown in many studies. Professor Johann Apps has shown that in his, which I'll show you in a moment, amongst many others. And they do fail. And they do fail for the best of us. Why is that? Well, what we're looking to anesthetize here is the inferior alveolar nerve. But that molar is innervated inconsistently by many other nerves which come through accessory or nutrient canals into the mandible and supply sensation to the teeth. Prof. Johann Apps showed this very clearly in his studies, and he determined that 95% of us human beings have at least one accessory canal, and in those 95% of patients they could have up to 11, and he demonstrated that clearly. So he concluded effectively that any nerves that are not originating from the mandibular nerve can only be anesthetized if you place anesthetic solution directly into the bone. Basically, my colleague Stefan has shown very clearly that human nerve systems are very complex, like an electric circuit. But unlike an electric circuit, if you wanted to turn one part of the circuit off, you just disconnect a wire. In the human being, you can't do that. So he said neurovascular bundles that do not originate from the mandibular nerve will only be anesthetized if you inject anesthetic into the bone. So going back to our original abstract of anesthesia forming the relationship that we have with our patients, new technologies are now available which will effectively solve all those problems. Electronically assisted injection systems and intraosseous techniques will allow you to give a completely reliable and instant anesthesia. So let's look first at the concept of the electronic delivery. If we look at this animation, this is an animation showing a traditional infiltration. So we deliver a bolus of anesthetic in the soft tissue. However slowly we think we're going, we're still delivering that faster than the vasoconstrictors can shut down those vessels. So what happens is you get a big spread of anesthetic effect. That means two things. One is you get a much reduced concentration at the site that you wanted, and you also get a much larger spread of the collateral numbness. Let's compare that then with the electronic technique. So with these devices, the electronic technique will deliver anesthetic into the soft tissue here, in this case, much more slowly, literally drop by drop at first. That allows the vasoconstrictors to kick in and start to shut down the vessels. So all of the subsequent solution will be delivered into an area that is shut down. So two things, you will get a much more concentrated effect where you want it, and you will get a vastly reduced area of collateral numbness. So that is the electronic delivery, the advantages of the electronic delivery only. Let's move on swiftly then to intraosseous anesthesia. So with these devices, we are going to be looking very firmly at where that target is. Where do we want the anesthetic to be? So if we're treating a tooth, be it a hot tooth or treating the tooth routinely, we would like to get our anesthetic as close to the apex of that tooth as possible. It's the last common denominator where the nerves from whatever source will enter the tooth and innervate the pulp. Intraosseous anesthesia is not new. Back in 1906, Dr. Nogi in France, he described what he called diploic anesthesia. And what he meant by that was diploic. He was talking about like a sandwich effect. 2 cortical plates sandwiching a volume of cancellous bone, just as the dental alveolar structure is. And what he described that was as like a box, a chamber. And what he said there clearly in 1906 was, if you can fill that chamber full of anaesthetic solution, analgesia, he said in the literature, is immediate and absolute. And this is the effect that we're looking to create in the most modern and comfortable way. So I'm going to take you fast through an animation showing you the process that I'm going to be describing to you this evening. A special needle, which I will show you in a moment, is delivered at a very shallow angle at the base of the papilla, where drop by drop electronic delivery anaesthetizes the periosteum and creates a little area of residual blanching. That means that when you reorientate the same needle and make physical contact with the bone, there is no discomfort for the patient, no feeling at all. That same needle then rotates intermittently and delivers that needle very lightly and gently through the cortical plate, completely painlessly into the cancellous bone. All you're looking to do is to gain access to that chamber. Once you have gained access to the cancellous bone, the electronic delivery then injects anaesthetic solution into that bone. And depending on the number of teeth you're treating, the size of your patient, once you have delivered anaesthetic into that bone, all of the teeth are instantly anaesthetized. What is very special is that you do not need a second injection. Why is that? There is no need for a supplemental injection, so you don't have to give palatal injections anymore or lingual injections. To explain that, let's take another animation. Infiltration, routine infiltration. A bolus of anaesthetic solution is delivered external to the cortical plate into the soft tissues. Periosteum goes numb straight away, but we now have to wait for the anaesthetic solution to diffuse through the cortical plate, through the Haversian system and the Volkmann canals into the cancellous bone. So it is actually an intraosseous anaesthesia. However, we have had to wait, and in the meantime, the bulk of the solution you've delivered to your patient is sitting in the soft tissues. Let's compare that then with intraosseous anaesthesia. With intraosseous anaesthesia, we're cutting out the middleman. We're now delivering anaesthetic solution directly into the cancellous bone, but you still get the diffusion out through the cortical plates, through the same Haversian system and the Volkmann canals. So all of the periosteum all round the dental alveolar structure will instantly be anaesthetized as well. And with it, all of the attached gingival tissues. That means that the lingual or palatal tissues will also be instantly anaesthetized. No need for a second injection. Withdraw the needle at that point, pick up a set of forceps, and you can take that tooth out immediately. There is no delay. So the benefits of intraosseous anaesthesia. Immediate effect even for hot mandibular molars. Completely stressless and painless anaesthesia. When you choose to join us on one of our courses that Swallow Dental run, you'll be able to see that this whole process is a very calm process. I always use what I call my anaesthetic voice. It drops. I'm very close to the patient. You'll see the number of contact points I have with my patient. It's a very almost like hypnotic, calming situation. The patient will feel nothing of discomfort. They'll just be aware of a slight vibration, but you've told them that's coming. So the stress is gone, both for the patient, but also for you as a practitioner, because you're no longer worried about hurting your patients. That patient will walk away without any numbness of the lip or the face, full motor function. You'll see 2 examples of that in a little bit. This, you can appreciate, from a business point of view, increases your customer loyalty and your retention of patients, and is a wonderful practice builder along those lines. Word of mouth is stunning. Better appointment management. Your time in the day can now be shrunk and made very efficient because you know how long each procedure will take. You will not have to wait, and you will also not have to repeat injections. This increases profitability thanks to the time saving. So thanks to Dr. Santosh Patil, who is a stunning photographer, as well as an excellent dentist. You can see just in these pictures the 3 stages. Stage 1 is that first mucosal delivery to anaesthetize the periosteum. Stage 2 is the penetration of the cortical plate and the gentle delivery of the needle into the cancellous bone. And stage 3 is the delivery of the anaesthetic solution into the cancellous bone. There is one particular thing that is different about maxilla and mandible, and it's all to do with the blood supply. In the maxilla, there is an omnidirectional or multi-directional blood supply. The significance of that is wherever you choose to deliver the anaesthetic, you will get a symmetrical spread of the anaesthetic effect, mesially, distally, palatally, buccally. It will go in all directions evenly. In the mandible, there's a subtle difference. There is a unilateral blood supply coming from distal to mesial. I like to think of it as a gentle wind blowing forward, and indeed you get a biased effect of the anaesthesia to the mesial. So you can see here, if the anaesthetic is delivered between the lower left first and second molars, I would treat the second molar if it was symptom free, but you will get many more teeth anaesthetized to mesial for any given volume you've injected. If that second molar was hot and it was a pulpitic tooth, I would definitely want to deliver distally to that, which is extremely easy. Another factor we need to get out of our heads, another paradigm shift, is that in the midline, where we're now used to in the mandible, delivering anaesthetic here on the left, if we want to treat a tooth on the left, but we wouldn't be able to expect any teeth on the right to be anaesthetized, that is no longer a barrier, because there is no barrier in the midline in the center of the bone. So if I couldn't get in on the right here, because of pathology, or if the teeth roots were very close together, I could deliver perfectly happily on the left and reliably expect the anaesthesia to travel across the midline to the right hand side. Full arch anaesthesia can be gained very easily in the mandible with 3 injections in the far distal of the mandible and 1 in the midline, far distal of the mandible, and in the maxilla you'll notice not so far back because we've got that symmetrical spread. So 3 injections of minimum volume of solution will give you full arch anaesthesia. So another Dr. Santosh Patil, I'll ask you to think about how long it would actually take you to extract a simple extraction for an upper left lateral incisor. So we've got here the stage 1, we've got the stage 2, delivery of the penetration of the bone, and stage 3 was the filling up of the bone, and then straight away forceps can be brought to bear, or elevator, or whatever you choose to use, and the tooth is removed. A lovely socket, it fills with blood very nicely, but it is not bleeding actively. And that can all be done in 3.5 minutes. It can sometimes be embarrassingly fast. Now, I'm not suggesting we all rush through our patients and rush them in and out of the chair. That's not what this is about. This is about comfort, calmness, and smooth efficiency. The way, otherwise put, to serenity. So let's look at that in a real scenario. This is a mandibular intraosseous anaesthesia. You can see clearly here that drop by drop delivery will create a residual blanching at the base of the papilla. That blanching stays there. You can now reorientate the device, make positive contact with bone, and when you've got positive contact with bone with no feeling from the patient whatsoever, you warn the patient there will be a little buzz, a little vibration, and the needle will rotate. And it rotates gently and intermittently. The computer on the device is controlling everything. All you do is put your foot on the pedal, and it just drops, you saw there, through the cortical plate. And once it is at the required depth, and of course, good discipline with needles means you never deliver that needle up to the hub, about 4 millimeters showing of a 12 millimeters in the bone, so it's a 16 millimeter needle, and now deliver the anaesthetic. Once you've delivered that anaesthetic, you just remove the device and pick up your handpiece and you're away. Obviously, it is important when your patients are experiencing this for a first time to talk to them all the time. I talk incessantly. You won't believe this of me, but I do talk quite a lot. And I talk very calmly to my patients all the way through this, telling them what they're going to feel, not what I'm doing, what they're going to feel. And if you tell them that and it happens, just think of the trust you're building. The equivalent of an ID block, an inferior alveolar nerve block, is just in what we call the retromolar trigonum, just medial to the external oblique ridge. Nice big volume of bone. You don't need any great depth here. It's the thinnest part of the cortical plate in posterior mandible, and that just with a couple of rotations drops in and you're away. Full cartridge in that area will give you anaesthesia of 8, 7, 6, 5, with smaller people, sometimes 4 as well. So it's very comprehensive. And that's the site we're looking at, just lateral to the second permanent molar, just medial to the external oblique ridge. That's the little groove which you'll be able to feel on your patients, which we're aiming for. Implant surgery is something I use this for all the time. And that is completely possible. I'm not going to go into any details now, but I've broken it down into 3 stages, 3 different classes, if you like, from simple transmucosal through to small flaps, through to full complete flaps. So I asked myself many years ago, what do I actually use this for? And I suddenly realized everything. One of the things that we all recognize is that something that is slightly new like this does have a little bit of a learning curve. And I was determined not to prolong this learning curve. So what I actually did was I got my team to take all of my syringes, put them in a Tupperware box and take them somewhere in the practice that I didn't know where they were. And when I walked out of the practice for the last time a few years ago, I still don't know where they went. I never needed it again. This was my only anaesthetic tool. 96% I worked out intraosseous, about 4% when I didn't need the bone, the osseous anaesthesia. So biopsies, purely soft tissue manipulation. So painless, that is a huge statement I'm making, but I want to show you how that can be. A standard needle has a point. It has 3 bevels, which renders a point. It tears the tissue slightly if you look at it microscopically. The Epitech needle, which comes with this system, is different. It just has 2 bevels, has a 1 long bevel, and then it has a little back cut, and that renders a scalpel. So the action is not to put it into the tissue like a standard needle. The action is to put it on the tissue and push down toward the tissue with the tip of the needle, and then start the drop by drop delivery. And that will render it, the scalpel will render itself submucosal. And what we're aiming to do, even in the tightest, the thinnest and the most healthy of biotypes, we're always going to be staying away from periosteum, because of course that's what you don't want to touch when the patient is not anaesthetized. That drop by drop delivery by the system is extremely slow, slower than I would put it any of us could create with just a manual syringe. So this is just a video showing how slow that really is. And of course, this is an exaggerated graph showing me the last patient of the day on a Wednesday trying to get home to see the Speedway, and so I go a little bit too fast into the soft tissues, and the patient goes, oh, I didn't like that very much. So I say terribly sorry, because I'm very British, and I back off, and then I start going a little bit again, and there's a little more pain. Now that's obviously a gross exaggeration, but compare it with what an electronic delivery does. Starts off really slowly, and the computer itself will ramp that up to give you the full dose. And you can imagine that when you're now putting that anaesthetic in electronically, the tissue's already anaesthetized locally. So with the electronic...
Andrew,
yes.
Sorry, just quickly, because we was talking about the needles and I don't want it to go past. We've just got a quick question saying the needle is a special one, or like the common needle, like 30G, only the injection machine are different. So I think it's just to re-go over, it's the different special needle, isn't it?
Absolutely, yes. This will... I mean, you could use a standard needle, of course. It will not be as efficient getting through the cortical plate, because this needle, the Epitech needle, is designed to get through the cortical plate, but it's also designed to, as I just said, to create that very completely painless entry into the tissue. But it is a needle which is readily available from Swallow, and I'm not going to ask Stacey to go into all of the costs associated with it. All I can tell you is that the Effitech needles are only a very, very slight increase in cost from your standard needle. So yeah, readily available. You'll never have any worries with those. I hope that helps that question.
Yeah, and again, I'm not going to go into cost and stuff, but if anyone did buy the machine, we actually send a large bulk of all needle sizes as well. So you'd be set up for a while with the needles, but I'll leave that bit to the end. Thank you, Andrew.
Thank you, Stacey. So to get a good result, get a painless result, you've got this electronically controlled injection speed and a very high precision and control. We talked about having the traditional syringe 1.5 miles away from your patient, but you can imagine, and you'll see in the videos in a moment, when you're holding a device like a pen, all your other fingers are supporting on the soft tissues of the patient, on the hard tissues of the patient, and tiny, tiny movements with your fingers, just like you were writing, means that you get an incredible control over the tip of that needle. So the support points are critical. Here's the example of the 1.5 miles away, and you can see the devices here can be held very close to the patient with bimanual support. So the patient is extremely protected and comfortable. So how do we plan these cases? Well, primarily it's a combination. It's a combination of radiographic and clinical examination. So radiographically, what we're looking for basically is a volume of bone, of an accessible volume of bone. Now, not all patients are like this. There are also, even in this example, there are little red dots there showing where it's inappropriate to go. But does it matter if those areas are inappropriate? Absolutely not. This is one big chamber, one big box. All we need to do is gain access to it. So if we can't get right next to the tooth we want to treat, it's not a problem at all. We go just a little further away at the nearest good access point and deliver anaesthetic. Radiographs themselves can be a little bit confusing sometimes. In this example, we've got a PA of lower left, and between the first and second molar there, I would look at that and I'd think, well, I'm not going to want to get a needle in there. But actually, it's not true. So I go to the mouth and I look, because this is exactly the same patient. And you can see that actually there is lots of room there. All you've got here is a two-dimensional PA, which might be at a slightly different angle from the teeth and the dental arch and the radiograph, and it's just basically squished those two roots together radiographically. But there's plenty of room, and you can see this quite often when you look in the mouth. It may be an imbrication, it may be just crowding, it may be a twisted tooth, a rotated tooth. Imagine a two-rooted premolar, for example. Twisted looks much wider, but of course, looking clinically, there's always an area where the root has been twisted away from, and you can find bone where it would once have been. Anaesthetic products that we use. The protocol standard would be a 4% articaine in 1 in 200,000 adrenaline. That is going to give you a good, serene 30 to 45 minutes of complete numbness. If you've got a slightly longer appointment, and I did a lot of CAD/CAM work, and so I wanted at least an hour, 4% articaine in 1 in 100,000 would give you, in my experience, from 45 at the very, very minimum, if it's a hot tooth, to 75 minutes, in my experience. But statistically, it's been said that 45 to 60 minutes of complete peace. Topping up, by the way, is absolutely no problem, because the patient has already experienced it. They know it's not a problem. You just get back into exactly the same position, and you've got a lovely little red spot there sitting on the attached gingival tissues. Aim for that, get into the same position, and it's rare not to fall back straight down the same osteotomy without further rotations. But of course, you can rotate very easily if you want. Endodontists or dentists treating extremely hot teeth would love a 2% lidocaine in 1 in 80,000, and that's going to give you up to an hour and a half easily of complete serenity. So you have options, you have controls, and the controls can be summarized in Stefan Diaz's diagram here. I said before that ideally you'd want to be as close to the tooth as possible. If you are on the bottom line there as close to the tooth, like right next to it, then you probably only need the most minimal volume, perhaps just 1/4 of a cartridge. You'll always deliver less intraosseously than you ever would have when you're filling up the soft tissues full of anaesthetic solution. If, however, like I said earlier, the teeth are imbricated, there's pathology locally, and I wouldn't want to inject into that, I would find the nearest available spot. Remember, in the mandible, it would be distal. In the maxilla, it doesn't matter. So if I would find that it was a little further away, the further away it is, the bigger the volume I deliver. And of course, you can deliver up to a full cartridge, which would pretty much take out a quadrant. The other control you have is over how long that appointment lasts. So 1 in 200,000, 30 to 45 minutes, 1 in 100,000, 45 to 60 minutes. I've known it longer, and 1 in 80,000 up to 1.5 hours. So we started off looking at archaic dental equipment. I can tell you now that dental equipment has evolved in anaesthesia, and all of this is available right now, and I've been using this now for over 16 years as my exclusive only anaesthetic technique. So summarizing, for the patients, we have no painless procedure. We have no numbness of the face, no loss of motor function, calm, happy, serene patients who, quite frankly, I've had patients who've come to me as we've always specialized, as it were, in very nervous patients, because we've always had a calming atmosphere in the practice, and they come in very frightened, and they suddenly realize that there's nothing here to be frightened of, and it's incredible the transformation that you can get with a patient. I think it's the extreme nature of it which makes the difference. For the dentist, there's a lot of advantages too. Predictable effectiveness on hot teeth. This is definitely an ROI in the time that we'll show in a moment. Immediate action, time saving again. Stress, you can't put a price on stress, can you? Stress is something that is deeply damaging to us over many years, and that can be something of the past. Okay, we'll still have stresses. I think we need stress largely to get through the day, but we don't want excessive stress. No post-operative side effects, very cost efficient. All you will need for any one case, anaesthetic wise, will be 1 cartridge and 1 needle. That's all you'll need. And I said I'd come back to this chart. If you take that 135 minutes per week that you have lost through sitting waiting for anaesthesia to work, and you then convert that with your hourly rate, if you run an hourly rate, that's when it starts to become incredibly worrying. That 135 minutes, if you've got a hourly rate of 400, you're looking at a monthly lost opportunity of 3,600. This, as I said, is just a conservative example. If you get this spreadsheet from Swallow Dental, Stacey will be able to get you access to it, and put your own figures in. I think that number at the bottom, as it did for me, is really quite alarming. So for the dentist, very cost efficient. And appointment optimization. One thing which is really interesting, and that is I used to, and I remember this from the old days, if I had a full list that day and an emergency came in and we never wanted to turn them away, we would say, sit and wait. When I got an opportunity to see them, they'd come into the room between 2 other patients. I would talk to them, we'd do a diagnosis, we'd get consent, we would any special tests, and we would anaesthetize them with consent and sit them back outside. How many of us have done that? They then might be waiting quite some time. I've known people who've been in pain, probably haven't slept for a few nights. They've come in, I've anaesthetized them, I've sent them back out to the waiting room or right outside the room, and when I open the door to finally receive them, they're fast asleep. And this is real, because they've suddenly, all of that fatigue has caught up with them. They're now numb, they're gone. So what have I done for the last 16 years? I have never sat a patient back outside, simply because between patients, You can get them in, you can discuss the problem with them, you can diagnose, you can consent, you can anaesthetize with the quick sleeper and do the emergency treatment there and then. There is no waiting. How efficient is that? So, management of emergencies. And of course, your increased practice image and reputation. And this is something that you can use. You can use to your advantage. We are lucky in the UK, we have the ability to market ourselves. There is absolutely no shame in when you've got faithful, trusting patients, they will want to talk about you. So look for testimonies, look for them. I'd like to introduce you to Christine. Christine was a patient of mine for many years before, since she was a teenager. She's now sitting here in the chair back, about 16 years ago. She's got teenagers of her own who are at university, and she came in on this day and for the first time had an intraosseous anaesthesia with quick sleeper. And she sat up afterwards and she went over to the spittoon just to have a little rinse, and she made this funny little noise. And I said, "You all right, Christine?" And she said, "Yeah, I just not quite sure what you've just done. I don't feel you've done anything. I know we've done some treatment, but I didn't feel a thing." And I said, "Just stop. I said, "If I hold this phone, would you say that again?" And of course she was delighted to, and Christine is very proud because she comes all over the world with me now. So turn your volumes up if you would, and just listen to what she has to say, but also look at her mouth. She has had the equivalent of a right ID block. So she's had a posterior mandibular intraosseous anaesthesia, where you'd normally expect her to have a numb face with traditional techniques. But this is what she said.
I've just had a filling, and Andrew's used the quick sleeper to numb my tooth, and it just feels fantastic. I can't tell any difference. It feels just the same as when I came in. I wouldn't know at all. It's so much better. It's fantastic.
Thank you, Christine. Thank you, Christine. So just after COVID, there was also a situation where I was able to give another mandibular anaesthesia for an active live treatment. And the purpose of this really was to demonstrate that there was no break. You saw clinical video earlier, and you were never sure quite what the time span was between the giving of the anaesthesia and doing the treatment, because it cuts and it's edited. So I was going to be making a video showing the whole process with no cuts at all. I'm not going to show you that now because that's fairly long, but I will show you the patient's reaction afterwards, and I will then tell you how long that appointment actually was.
I've had some great testimonial videos from patients straight after treatment, showing clearly that they've got no loss of function, no droopy lips. Patients often ask for that no numbness anaesthetic when they're going to have a subsequent dental appointment, because they perceive also that there is actually no needle involved in the process. It really is that comfortable.
Honestly, previously when I've had this sort of treatment before, I've had to psych myself up for the needle part, but I didn't honestly feel a thing. Slight vibration that lasted no more than 10 seconds, and then straight away into the procedure, and I feel like I've only been here 15 minutes, so it was much better than that other previous treatments. I feel like I can go drink hot drinks, I can go straight to work. I don't feel like there's any slurriness in my speech, or I don't feel numb at all. I literally feel as if I've come in, just had a chat with you, and then next thing you know, I've had the filling. I don't even feel I can move my tongue, and there's no sharp bits. I just feel like I can just go back to work now and just carry on the rest of my day not feeling numb.
So thank you, Christina. Now, I want to point out that not all of my patients were called Christine and Christina. I did have patients called other things. But yes, I'm sorry about my voice there. It was just in the recovery period after COVID, and so I had that respirator on, so my voice was a little bit muffled, and I apologize for that. Going back to that appointment though, it was another interesting lesson, because I did that live video and I did not edit it. It was raw, and from first point of contact with the needle to the finishing of a class 2 prep on the lower left first molar, it would be interesting to know how you all think how long all that would take. But I'm going to spoil the party by saying that from first point of needle contact that you saw there briefly on my head cam, to having put the device down, picked up the air turbine, gone straight and positively and confidently to remove the old composite, straight down to dentine. No blowing air, seeing if it's numb. I just went straight in there, and I went straight in there because I knew it was numb. I knew it would be numb. So I prepped that tooth, I got rid of the secondary caries, and I checked it with a mirror and stopped the clot. And at that point, I was able to tell you right now that that was 5 minutes and 16 seconds. So no rush. I did not rush this. This was just a continuous, efficient flow of clinical activity. And 5 minutes, 16 seconds. Look at what time this is saving in your day. It is a terrific return on investment. So what I would say is there's a lot of training. There's a lot of training that is provided by Swallow Dental, and Stacey will tell you what all of her exciting news on upcoming courses at the end of this. But the gentleman on the left there is Eric from France, and he calls himself my spiritual father, and I call I'm his spiritual son. He was the one that taught me originally. Since then, as I say, haven't looked back. But training exists, and I am here to support you wherever you are in the process, from the very beginning right the way through to questions as you come across something that you've never come across before. Always here to support. And Stacey is here representing Swallow Dental, who are also an exceptionally good customer service company. I have never had anything but great customer service from Swallow, and I'm not saying that just because Stacey's there, even though I do, as I said at the beginning, do exactly what I'm told by her. But pick up the phone to Swallow, and things are sorted really, really quickly. So very impressive. So I'm going to just say thank you, and then I'm going to go back to Swallow's screen there, and I would welcome any questions from you. I would welcome any contact you have. You can get hold of me through that QR code if you want to. I'll leave that up there for a short period of time, so I can answer questions directly, but certainly Stacey and her team at Swallow will get you through to me anytime you want. They'll also answer any questions from a practical point of view. So thank you again, all of you, for coming out on a Wednesday night, and I'll hand you back to Stacey.
Thank you, Andrew. Apologies if my camera's not on. I don't know if you can see me, Andrew, but it's just decided to malfunction and not work. So hopefully you can hear me okay.
We can hear you very clearly, yes.
Thank you. So as Andrew mentioned, Swallow Dental, we have a team of 4 reps out in the area. So we've got North and Midlands, South East and South West. You can contact any of our local reps, myself, or even just a customer care team that's on there. So we have the local reps that are happy to come and visit the practices and talk about it any further. However, we also do have 2 training dates that are booked in, and these are a practical course. It is a free course, but this is a really good opportunity to have a hands-on feel of the equipment. We get someone sat in a chair, don't we, Andrew, and we can do a bit of a practical session, and you can even try it out on yourselves to really feel just how good this product is. With the first one that is going to be coming up, it is going to be quite short notice. It's on the 13th of June. We have got a couple of free places left still, and that's going to be in Bracknell. And then we have one on the 4th of October in Nuneaton. If we do get the demand, I'm more than happy to put another date on as well, so we can look into that. But please do reach out if anybody would like to have a practical training course. Andrew, we do have a couple of questions actually.
Okay.
So, and a question I've got here is, how does it differ from the wand?
Chalk and cheese. Very good
Yeah.
question, and a question that we're asked quite a lot. The wand is not intraosseous at all. You're going to get of traditional techniques, and yes, it has got the slow delivery, which is superb, and it's exactly what you want for traditional techniques. And it will do intraligamentaries, and it will do palatals extremely comfortably. But does not have the same Effitech needle, which gives you that completely pain-free entry. And from a cost-effective point of view, there is a big difference between the two. Suffice to say that with the wand, I know the STA, you need the needle, the tube, and the cartridge holder each time, which adds an extra cost each time it's used, whereas this doesn't.
Thank you. And then another question we've got is, does intraosseous anaesthesia overcome LA failure due to apical pathology?
Yes, I can say that straight away.
Very confident.
The moment you have got that anaesthetic in the bone, everything in there is anaesthetized. The nerves. One thing we must always be aware of is that there are no nerve fibers that are myelinated in the bone. So that's why when the needle is passing through the cancellous bone, there is no discomfort, no sensation for the patient at all. There are no nerves that will transmit that feeling up to the brain. But there are pressure sensors in the bone. So when you've got an apical pathology, if you have got a pressurized area, then that is going always to threaten anesthesia. What you'll find is that pretty much every time you will get a full effective anesthesia by using the intraosseous technique. But we must always remember that, and what actually happens is if someone is already pressurized in the bone, the quick sleeper device has a number of settings. So its standard setting is, I can even press the button and make it happen there. So where's my camera?
Do you want to stop sharing the slides? Because I think we've got the information. If you stop sharing the slides, you'll become bigger on the screen so we can see that. That might help.
Am I bigger?
Yes, you're bigger now.
How wonderful.
Let's pick.
Thank you, Stacey. So on the device, there are three settings. There is the standard IO in the middle, then there is low, which is the same as IO, so it will go through those three-stage process in exactly the same way, but there is also high. So if you are delivering too fast in the standard, you can always drop down to low, and that will create a slower rise, and that beats any discomfort caused by pressure. But one thing I can tell you with my hand on my heart is that all of the nerves will be gone. They will be anesthetized. But the pressure is sometimes something which you just need to manage by being just that much more gentle. I hope that helps with the answer.
I think that was very clear. Yeah, that was very good. We've got another question. Can I meet the rep and have a trial at the practice? And also, are you attending the dentistry show? So this is obviously a question for myself. You can have the rep come to the practice, but unfortunately you wouldn't be able to trial it at the practice purely just because we don't have a clinical, we've got a demo one, but we don't have a clinical one to trial. And not just that, our reps are not clinically trained to sort of oversee you having it go for the first time. This is why we do highly encourage anyone to come onto the courses, because it'd be either Andrew or we've got Celia, who are our clinical trainers, to do the actual training where you can have a hands-on go there. It being intraosseous, it's very difficult for my reps to give clinical advice.
Yeah, if I could add there, Stacey, the beauty of the courses is that you get that hands-on feel of how it is in the chair. This, however complex this sounds when you're looking at it cold, it is actually very, very simple as long as some simple protocols are followed. And one of the protocols will be the positions around the chair. For mandibular penetrations, it's extraordinary. But if you get round to 1 o'clock to the patient and you're coming from this direction, your view and your control over the patient is sublime. And you saw me doing that actually in that video just post-COVID. So these are the things that really, if you can pick those up at a basic training course, which has, as Stacey said, no cost to you, it really makes it fly.
Yeah, it does. It's a good one. And unfortunately, we're not attending the dentistry show. I will be there myself. Going through, I'm going to go see some of our suppliers, so I will be visiting myself, but we don't have a stand there, unfortunately, this year. So I do apologise on that one. The next question we've got, this is a good question actually. Are therapists allowed to perform this technique on completion of your training course? Intraosseous anaesthesia was not part of my undergraduate training.
Absolutely correct. This is very much a new technique, new system, although on an old concept. The straight answer to your question is, at the moment, it is all down to your indemnity. I have been in dialogue with the GDC for quite some time now, because as we all know, things don't move very fast in higher circles, but the scope of practice is currently being rewritten to make it less prescriptive, more flexible. And one of the conclusions that the GDC have made is that someone can practice anything within the bounds of their treatment capabilities, as long as they are trained, certified, and indemnified. This is what the GDC have said. So it's the indemnification. We can provide training. We can provide you with a certificate to say you have done that training. It's all down to your indemnity. I have tried to contact a few of the indemnity companies, but I mean this is a work in progress, really. Yeah. But I hope that answers your question. It's not the most positive answer, but we do have, and I've had therapists, dental hygienists, and therapists who've been on the courses. One of which is an owner of a practice who gives intraosseous anaesthesia all the time as a therapist. Now that is in negotiation between her and her indemnity. So the answer is potentially yes.
Perfect.
It's a very exciting prospect, but I have been working on that.
Thank you, Andrew. And yeah, we all know the GDC takes a while to get through to. And then another last question I've got is, are there any more courses being organised in Bracknell after the 13th of June? It is the only one currently this year that we do have. I do know we're in the process of putting another course on in November, but that would be more north. But do keep an eye out for our social media pages or our websites. We are updating any more future courses as soon as possible on there, but currently that is the only two that we've currently got on at the minute.
In my experience, if there's demand for a course, Swallow are very good at creating a course.
For sure.
Yeah.
Sorry, my dog is going mental if anyone can hear that. But that's everything from me. I just want to thank everybody for attending on a Wednesday evening. Like you said, Andrew, I'm sure sometimes there's better things to be doing. Like walking my dog. That's why he's going mental. But yeah, thank you so much. If anybody does have any questions, please do reach out to the contact that has been given, and we're more than happy to answer any questions. But yeah, thank you.
Thank you all very much.
Have a lovely evening, everybody, and I hope everybody can at least enjoy the last little bit of the sun.
Yep, it's still out there.
Perfect. Thank you so much.
Thank you all. Bye-bye.